Without further ado, I would like to introduce Patrice Rioux, who is the co-founder, director, and chief executive officer of Thiogenesis Therapeutics. Welcome.
Let me try to share. Yep. Good afternoon. Actually, although for me it's still morning because I'm in San Diego. So Thiogenesis Therapeutics, you've seen the name earlier in a slide from Marnie Falk. That's despite being in San Diego, that's a Canadian company based in Toronto. And we are actually what we call publicly traded, that is on the Toronto Stock Exchange. So that's why we have to put all this statement for as usual for public company. So let me summarize where we are. So mitochondria, as you know, is producing most of the energy for the cell. And that's, let's do a little bit of history. That's what we knew when I started working on that. So 25 years ago, I moved to Boston with Biogen, and then I joined another company, Repligen, where we started working on production of ATP with people like Bob Nevio and Richard Haas and Bruce Cohen, who is now at Akron, and some others. And so we were trying to produce more ATP, but we didn't succeed really. So I moved very quickly. I moved after that to California to start a company you also probably know, which was Edison Pharmaceuticals. I started with Guy Miller, and we worked on quinones. You've heard this morning, we started with A00001 for Friedreich's ataxia, and then we worked with a compound called, I did the first emergency IND with EP743. But we had some financial issues later on. And so I left and went working for a company called Raptor Pharmaceuticals. Raptor Pharmaceuticals, the goal was to develop a new formulation of a drug, a very old drug, cysteamine, which has been used initially for the treatment of irradiation in nuclear plants in USSR and then in the US and everywhere. And it works well, actually, except that you have to use very high dose and very frequently, to the point that effectively for the kids it has been approved for only one indication in the US and Europe, which is cystinosis. Why? Because it's a life-threatening disease like any other rare disease, and it's a lysosomal disease. So the treatment is such that using cysteamine, you have to use it every 6 hours and at very high dose. Very high dose means side effects, and 6 hours means you have the side effects every 6 hours strictly. So there were even papers showing that the kids who are treated with very high dose of cysteamine, they have nausea, vomiting, and everything, and they have that every 6 hours because they cannot even go for 8 hours of sleep and something like that. It has to be, if you want to protect your kidney function, you have to take it. And that's what actually it worked for the kids who are really sticking to the schedule. But with Raptor, we developed a new formulation based on a license from UCSD, and that was allowing to use a drug every 12 hours instead of every 6 hours, which was really a progress for the kids, you can imagine, but not really that much in the terms of the side effects were still here because we were still using a lot of very high dose. So, but at that time, I heard from Greg Hens in Stanford, following the clinical trials with EP743, that the patients who would respond, who seemed to be responders to EP743, were those who had an increase in glutathione. And so I said, that's something with cysteamine, which is very well known from the first time we used it. It increases glutathione, except that it has to be with very high dose and every 6 hours, strictly every 6 hours. So let me explain a little bit more So as you know, leaking, the problem with mutation in mtDNA, or if actually even nuclear, that basically it leads to a leak of electrons in the electron transport chain. And that generates what we call reactive oxygen species, ROS. The issue is that ROS so far has been very promising, but not really working for other disease actually, except for cancer. In cancer, it's actually working in the sense that it has been shown that if you actually combine the inhibition of glutathione and thioredoxin, which are two very strong antioxidants, you kill the cancer cells, which means that these two antioxidants are effectively good enough, but also necessary for surviving or for killing for inhibiting the ROS. And so on the other hand, it's always good to have a little bit of ROS because it's used for signaling, for actually triggering inflammation reaction and all these cytokines and everything else. But if you have too much ROS, it's going to kill the mitochondria. So how to prevent that? How to inhibit the production, or inhibit the production, which is the case when you use AP743 or CoQ10 or others. That's the goal. But here, our approach was to say, okay, we're going to try to annihilate these ROS. And so using a compound, using cysteamine, because it's actually well known, but in a different way, in the sense that we have to use a version of cysteamine that would be effectively no side effects and not every 6 hours as shown for other patients. So we patented a new compound, which is a relatively big compound, which is such that when you give this compound, you get 2 molecules of cysteamine and 1 molecule of vitamin B5 in the GI. But at the end, despite being a new chemical entity, it's absorbed, only cysteamine is absorbed. And so that's why we can go directly into patients as a prodrug for cysteamine. And that's what we are going to do actually very soon. So basically, you know this, so I'm not going to go in details about the leak of electrons and what I've said actually about the ROS. So what's the way it works with glutathione, which is the best compound for neutralizing ROS, you have on the left actually the fact that when you have 2 molecules of GSH, of glutathione, and some peroxide, which is the basic ROS, but you have very different ones. But basically, you know, when you go to S hardware, that the peroxide is very good at killing everything. And so every bacteria and everything. So the way to prevent that, if you actually mix the GSH and the peroxide, 2 molecules of GSH join the peroxide and produce actually what we call a disulfide, GSSG, the disulfide of glutathione, and water. So that's the best easy way to prevent building of ROS. So what the problem is, and on the left here, you have why it doesn't work. The problem here is what we see in the mitochondria. In the mitochondria, when we try to use to have an impact on the electron transport chain, which is, as you can see here in green, you have all these compounds, but plenty of other compounds like AP743 or others. Actually, we try to modify the production of peroxide or ROS, but the problem is that these compounds are actually not getting there very much. Only one compound, actually 2, I said, thioredoxin and glutathione, are effectively going very much into the mitochondria. It's not produced, glutathione is not produced in the mitochondria, so it has to be imported from the cytoplasm. And so because of the medium, actually the inner part of the mitochondria is very different from the cytoplasm. So what appears is that glutathione is very well absorbed in the mitochondria because there is a specific transporter for that. So, and when there is more ROS in the mitochondria, there is more production of this transporter on the membrane. The issue is that there is more transporters on the membrane, but the mitochondria has no way to signal to the cytoplasm that it needs more glutathione. So if there is more glutathione in the cytoplasm, that's good because it goes into the mitochondria. But if there is not much glutathione, there is nothing happen, and so the mitochondria will die. So clearly, the goal is to increase in the cytoplasm the glutathione. How do you do that? You just actually have to make sure you have enough glutamate and glycine and cysteine, because there is an enzyme, which is the gamma-glutamyl transferase, which is a synthase, actually, but where the key parameter in there, you have always enough glutamate and glycine, but the key parameter is cysteine. So you have to increase cysteine in the cytoplasm. To increase cysteine in the cytoplasm, people tried actually NAC, cysteine, and other compounds, and it doesn't really work. Why? Because both NAC and cysteamine actually have to go through a place where there is the highest proportion of the highest quantity of cysteine. Cysteine is 2 cysteines. Always, most of the cysteine we have in the body is in form of cysteine. And so, but you have to be able to break this cysteine into cysteines to get more cysteine in the cytoplasm. To do that, and we know it works because that's the way we treat patients with cystinosis. We give them cysteamine, it goes into the lysosome where there is a huge amount of cysteine. And by interaction between a thiol and a disulfide, cysteamine and cysteine, there is a creation of a mixed disulfide, cysteamine, cysteine, and there is liberation of cysteine. This cysteine goes out in more proportion, in more quantity than in the cytoplasm. And it has been shown, like, effectively in patients with cystinosis, that's the way it works. So the problem and what we know that is that because clearly in patients with cystinosis, we have to give more cysteamine, but we know that as soon as it stops, the level goes down to the initial level at 6 hours. There is creation of cysteine during these 6 hours, but then as soon as you stop, cysteine actually increase again. And so we did a few clinical trials with this idea of actually using this new formulation. We did that in Huntington. We did that in mitochondrial disease with Greg Hens at Stanford, which was using what we called RP103. But it was, we had both actually, all the investigators in the study, Greg Hens, Fernando Scalia, Bruce Cohen, said, yeah, that's a very promising treatment, but we didn't have much time to use. We had to start the trial with very low dose because we didn't know exactly if it was not toxic for the mitochondria and everything. And so finally, we realized, and we did another clinical trial, pediatric NAFLD or NASH, and we realized that effectively, if we want that to work effectively as ROS, we have to make sure we have a high dose, which is not toxic. High dose, not toxic, but good enough. So what's going on is that we developed this new compound. What is interesting is that if we give cysteamine, the standard one, the old one, or Procis B is a little bit the same, but slightly delayed. So you have the black curve, the concentration in the blood. You see that there is a peak, relatively rapid peak, and then a decrease in 6 hours. And in 6 hours after that, you don't have enough drug to produce this concentration. On the other hand, based on the way the drug, our new compound is generated, you have a peak which is similar. And if you stay at this level of the peak, you actually don't have side effects. But on the other hand, what doesn't appear, because here in black, we have 600 meg of cystagon, of immediate release formulation. If you go, the green is actually the curve for 2400. So we give 4 times the dose. And despite giving 4 times the dose in healthy volunteers, despite giving 4 times the dose, we have the same peak. So which means that if we stay here, we won't have side effects. But what happened because of the metabolism and everything, it happened that instead of having a higher peak, we have a longer exposure. So we mean that we can actually, we can cover the 24 hours. So we can give a relatively high dose for 24 hours. And that's where we're going to develop that in 2 clinical trials. I'm going to be done soon. We can actually, we are starting a clinical trial in Leigh syndrome with a relatively with one dose actually relatively high in the US, and we have got an approval from the EMA to start a clinical trial in 2 centers in Europe for MELAS, which is a very similar mitochondrial disease. That should start, both actually should start before the end of this year with a compound, as I said, with a compound which has been considered as a prodrug. That's why we can start relatively quickly. And I think, yeah, I think that's it.
Wonderful, perfect timing.
Yeah.
Thank you very much for your presentation. It looks like you've had a very productive year.
Yes.
Everyone, please share your questions in the Q&A, and we will have a period of Q&A at the end. Thank you again. That was terrific.